severely atrophic maxilla. The upper anterior they got splintered, severe bone loss, alveolar bone loss. We will see the amount of bone loss in the vertical direction till the apex for premolars. Even the noticeable thing is even the tuberosity, the height has got reduced. Straight away the pterygoid annulus comes. Till the pterygoid annulus, the maxillary tuberosity has resolved. We will see the pano. We can observe here, this is the semitonemal junction part, this part. So from here to here, complete maxillary tuberosity and maxillary alveolar bone resorption has happened. This is the notch, this is the pterygoid annulus. So the bone resorption has happened till the notch. On both sides, this is the scenario. And not only that, the sinus has expanded till the floor, and not only that, anteriorly it is expanded till the nasomaxillary buttress. Nasomaxillary buttress width is very minimal here, almost non-existence. So there are three target points we can achieve in the tilted implant. One is the buttress, and another one is the nasal corner, another one is in the nasal floor. For this patient, we have to take only from the nasal corner, not from the nasomaxillary buttress, because the sinus is expanded till here. So the challenge is anteriorly we can place 3 or 4 implants from premolar to premolar. So what about the distal support? That is the question here. Whether we can go for a regular zygomatic implants, one zygomatic implants on either side, and 2 or 3 or 4 implants in the premaxilla. And another option is, we want to avoid zygoma, we have to place a pterygoid on both sides, connect with a titanium bar and give soft loading in the initial loading period. So we will see whether pterygoid is favorable or not. So this is the right side pterygoid. You see here the sinus has expanded very much. The crest has gone till the pterygoid notch. So the amount of bone remaining here is very limited. So we will see the buccolingual cross section. So if you place the implant, it will be only 10 mm implant, 10 mm or 11.5, that's it. Minimum diameter implant. This virtual implant is 3.5. We cannot use 4.2 from Norris, it will crush the bone, and 4.2 Norris doesn't have a shorter height, shorter length. That is also one drawback. Usually we think for pterygoid we need a 16 or 18, but it is not like that. For this patient it is around 11.5 or 10 or maximum 12, and also minimal diameter implant. And placing pterygoid in this very narrow zone is critical. Easily we can slip into the sinus, or we may fail to engage the pterygoid bone. So better to open the flap and mark the landmarks and take IOP after pilot drilling to know that you are not into the sinus, you are into the correct direction. So if you can follow these things, you can place a short implant, narrow diameter implant. Narrow diameter implant 3.5 is better. Either you can choose Neodent 3.5 or whatever company is offering 3.5 with apical taper is necessary. If the apex is flat, it may slip into the sinus, or you can use a CMU also. We will see the left pterygoid. We will see the left pterygoid. The left pterygoid is much worse than the right side. The sinus has expanded fully. The maxillary tuberosity has resolved even beyond the pterygoid annulus, very severe scenario. So only here in this thin bone we have to park the pterygoid implant. So only here you are getting the bone. Here also 10 mm or 11 mm or 12 mm. this much length only. We cannot place 16, 18 and all. Maybe we can try tilting it. The pterygoid is highly unfavorable in this left side. So same smaller diameter implant or CMU implant. Never above 3.7 or 4.2, don't place here. Surely we will crush the tuberosity and we may enter into the sinus or somewhere else. So considering the pterygoids are quite a little challenging, there are two options for the doctor now. One is either straight away go for zygomatic implants or go for pterygoid, but keep a backup option of zygoma. In case the pterygoid is not possible, immediately we should have a backup armamentarium skill set to place a zygoma. We will see the premaxillary plan, nasomaxillary buttress implant. So actually we cannot place a nasomaxillary buttress implant, we can engage only the nasal corner. So from first premolar we can tilt and we can place a good implant, minimal diameter implant, 3.5 or 3.75 also will be fine. Along the palatal wall, instead of the crestal approach, just start drilling the close to the palatal aspect and stay palatal. The bone quality is good. Anteriorly, you have the option of placing two implants or placing only one implant in the midline. I prefer placing only one implant in the midline. Nasopalatine canal is excellent in anatomy. You can place a implant straight away into the canal, 10 mm to 13 mm, 3.7 or 4 diameter, anything. And left tilted also it looks easy, but there is a depression above the canine eminence. If you see it, there is a undercut kind of concavity above the canine eminence, so that we should be careful, otherwise the drill may perforate here. And try palatal approach, start drilling close to the palatal edge and stay along the palatal border. Select a shorter diameter, don't place wider diameter implant. So anteriorly it looks pretty good. We should execute the surgical procedure very carefully. Considering the posterior support, as we already discussed, there are two options. One is zygoma or pterygoid. So always keep zygoma as a backup option for this patient before attempting.